Hi there, we're Group 1 and we're here to talk about the tissue layers of the head versus neck. Sorry for the slight layout change that the software decided to impose on us, but we'll go right ahead. So, the layers of the head, we get a really great acronym that says SCALP. So we start off with the skin, then the connective tissue, then the loose connective tissue, then the aponeurosis, and then the loose connective tissue, and then the pericranium. Then we obviously have the bone, and then we have the 3 layers of meninges. Scalp can be used to remember it easily and quickly. Now, the clinical relevance of the scalp is things like infections. For example, there's an infection called tinea capitis, which is commonly known as ringworm. Now, this is a fungal infection caused typically by poor hygiene or minor injuries to the scalp. It's very common in children, and the symptoms are a bulging of the affected area, chorions, which are small pus-filled cysts, also black spots on the affected area, fever and itching, which can lead to scarring if it's not monitored. To diagnose this, you use something called a Woods lamp, which is essentially a UV light, and you swab the area to test for fungi. To treat it, you use antifungals griseofulvin or terbinafine. Griseofulvin acts on the microtubules of the fungi, and terbinafine acts on the cell wall synthesis of the fungi and stops it. Further clinical relevance is lacerations. Lacerations of the scalp will cause profuse bleeding due to the numerous anastomosis of blood vessels in the area, and the walls of the arteries are attached heavily to the connective tissue, which will increase the bleeding further. Also, deep lacerations that involve the epicranial aponeurosis cause profuse bleeding due to the fact that due to the opposing pull of the occipiter frontalis muscle, the anterior and posterior bellies of which pull in opposite directions and pretty much pull the wound apart, if you like. Just as a side note, the blood supply to the skull comes from the medial meningeal artery, which means mostly from the medial meningeal artery, which means that if there is a scalp injury, if there is an injury to the scalp, there will not be bone necrosis. Further, the sebaceous cysts, which are epidermoid and pilous cysts, are benign, usually small lumps under the skin's surface, and they are usually painless. Epidermoid are intradermal and form from the epidermis. A pilous cyst forms from the base of hair follicles. Clinically, these are indistinguishable. They present as red, inflamed, and painful if they are infected, and they are treated by simple excision.
Okay. So we've talked a bit about the clinical relevance of the scalp. So now the deeper layers, the bone and the meninges. With regards to that, the first thing to talk about is the fractures of the bone. There's one in particular that's very relevant, and that's the fracture of the pterion, which is on the side of the head. It's a meeting point of a few different bones. Because it's a meeting point, and it's a lot thinner than everything else, it is probably the weakest area of the skull. And that can be life-threatening mainly because just underneath it in a bony groove lies the middle meningeal artery, which supplies blood to most of the skull. So if you damage the pterion, you could easily damage that vessel, and you're going to bleed out intracranial pressure and so on. The next thing is the hematomas, which come in 3 kinds really: the epidural, subdural, and subarachnoid. The difference between them really is just between which layers they are. So the epidural is between the actual bone and the dura mater. So that happened, it's of arterial origin. So if you break a bone, hemorrhage one of the vessels just underneath there, it will bleed out and actually split the dura mater from the bone. The next one, subdural. So subdural is in the space between the dura mater and the subarachnoid mater. There's not actually a space there, but if blood bleeds out from its venous origin, if that bleeds out, it's going to force a space in. And that happens, as you can see on the little diagram over there, there's a little, the superior sagittal sinus. There we go. So superior sagittal sinus, that's where all the blood collects, the venous blood. As the vessels kind of move into there, if they split as they move in, that's when they bleed out into this subdural space. The subarachnoid there is that's arterial origin again, and it's associated with cranial fractures and cerebral lacerations. So if you actually get bleeding in the brain, and that often results from damage to saccular side shoots of arteries. Apparently, arteries have kind of little diverticular type things going on. So now onto the neck, and this is just the anatomy of the neck. Outside, again, like the head, you have skin and subcutaneous fat and things out on the outside. You also have superficial layer fascia, and that's associated with the skin, really. So those things are on the outside. When you go deeper, you get the deep cervical fascia, which is 4 types, really. You get the investing layer, which is in the green there. Pretracheal fascia, which is in the purple. Carotid sheaths in the red, and then prevertebral in the orange. So the investing layer invests the trapezius and the sternocleidomastoids, and it acts as a corset to just keep everything in the neck. The pretracheal fascia, so that's just thyroid, the esophagus, and the trachea, and that keeps it in there. You've got the prevertebral fascia, which covers the vertebra and the muscles associated with it, and that goes all the way down the back. And then you've got finally the carotid fascia, and that's kind of gets some of its tissue from the prevertebral and the pretracheal, and that has the carotid artery, jugular vein, and vagus nerves, as well as some lymph nodes. So that's that, and that's just another little picture of it, sagittal plane. They're all in the same colours, so you've just got an extra bit of information there. And the clinical relevance of stuff to do with the neck, we came up with 2 main things, really: retropharyngeal abscesses and pharyngeal abscesses. So retropharyngeal occurs mostly in infants. The symptoms are stiff neck, malaise, difficulty swallowing, and fever, which you can appreciate is the quite common symptoms of a lot of different things. So it's difficult to diagnose medically. The main diagnosis tool used is CT or neck X-ray. If there is a space in the retropharyngeal area more than half the size of a C2 vertebra, it indicates an abscess. Causes: bacterial infections from the nasopharynx, tonsils, sinus, adenoids, middle, basically anything in the head and neck. It's such a compact space that infections can travel from anywhere to anywhere. And the treatments: surgery, tonsillectomy, and antibiotics, and they're relatively obvious what they do. Pharyngeal abscess, again, mostly in children and adolescents. Causes are tonsillitis and dental infections. The symptoms are very like a throat infection, so you get sore throat, nasal voice, fever. Treatments of surgery and antibiotics. And can lead to complications like respiratory obstruction. If you get larynx edema, you're going to get restriction of the trachea. Can lead to septicemia like most infections, and it can spread to the retropharyngeal space, which goes down to the mediastinum. There you go.
Very much. Thank you very much. I was very much on time. So I've taken some notes, and I'll then send you feedback to yourselves. In previous years, students didn't like my feedback, so I'll send it to you for your own consumption. Okay, can we have one of our critics? I think the first one is William Angus Brandley. Yes. Could you tell them what we thought was very good about the presentation?
Straight away.
Yeah.
I thought you both spoke very well. You were both confident. It seemed like you practiced it, rehearsed it. That was good. You had a good amount of elaboration on the slides, as in, like, you had what was written down, but then you also gave extra bits of information, which was good. It seemed to keep people listening. The pictures on the slides were really relevant and helped to explain what you were talking about. The pointer was nice. And everyone seemed to be watching throughout, and you kept their attention really well. So yeah, I thought it was really good.
Okay, thank you. Stephen Coulson?
Yeah, again, I thought it was pretty good.
No, that's not your job.
The only real problem I had was some of the slides had a lot of information on, so maybe just run it out over a few more slightly less right slides, but generally I thought it was pretty good.
You're scared to criticize. You'd be a ferret like me, so I understand. Are there any questions from the class? Did you wish for elaboration on certain points, or did you disagree with some points? I disagreed with 1 or 2 points. But anybody?